We're going to cover the medications you're responsible for that relate to Module 10 inflammation. We will go straight to Module 10B on gallbladder disease. We'll cover the drugs for cholelithiasis, or that's stones in the gallbladder. There is only one drug that is mentioned in your text, if it's even used at all. It's on page 690 in Pearson. You will not find this drug listed in your nursing drug handbook. Ursodiol or Actigol is used to dissolve gallstones in a patient that surgery is not an option, because the best is surgical removal. But if for any reason that person is in no condition or for surgery at that time, they can try to use this drug. It's actually shown to be very safe. It takes 4 to 6 weeks for it to be effective in dissolving the stone. It is a bile acid oral litholytic, or it's a bile acid stone dissolver. It doesn't impact their liver enzymes. It's shown to be effective in preventing complications from gallstone disease, which you probably covered or will be covering or have read in your text with Dr. Ferguson on gallstones, especially if it obstructs the bile duct. Recurrence of the gallstones occurs within 5 years in 50% of the people that have been treated with this. It can take between 6 and 12 months to dissolve the stones. It's the maximum amount of time for treatment is 12 months. If not effective at that time, they need to stop it. And if you notice the picture I gave you here, I've not seen one that bad, but I have seen pretty bad ones in surgery removing. You think of those stones and everything being blocked. So someone like that, I don't know that this drug would be effective, but at least there is an option there if surgery is not an option. Okay, so contraindications if they're allergic to bile acids, because it is a bile salt. If they have cholesterol stones, I think your text mentioned using it for cholesterol stones, but everything I found on this is that it's not effective for cholesterol stones. It's contraindicated if they have a complete biliary obstruction. If that bile duct's obstructed, they have to have immediate relief. They do not have 6 months to 12 months to get this cleared. If there's any reason that they absolutely need that cholecystectomy, like the gallbladder has completely failed, cholecystitis, and it's not squeezing, not functioning, that they're having those what do you call them? I wanted to say white stools. It's white stools, but they call them clay stools because there's no bile. That is an emergency. Patients who are not candidates for treatment for this drug due to the presence of calcified cholesterol stones or radiopaque stones or radiolucent bile pigment stones. Then patients with a compelling reason for cholecystectomy, like I mentioned, unremitting, it's not letting up acute cholecystitis, because some people can have gallbladder attacks that come and go, but if it's not stopping, not remitting. Cholangitis, if the colon, the duct, biliary obstruction, if all the ducts are inflamed. Gallstone pancreatitis, and biliogastrointestinal fistula. Those are all not candidates. The patient teaching, they need to swallow the tablet whole. If it's a liquid suspension, they need to shake it well. It teaches them that they will expect a bitter taste. It requires monitoring of their liver function tests, AST and ALT. Also, more liver function tests are your alkaline phosphatase, your bilirubin, and your GGT. So your AST, ALT, bilirubin, GGT, alkaline phosphatase, once a month for the first 3 months, and then every 3 to 6 months. It is contraindicated in pregnancy, so they need to avoid pregnancy and report if they are pregnant, because this drug needs to stop. Yes, people can get the gallbladder out during pregnancy. I have seen that. That is it for your gallbladder stones. We're going to go to your drugs for inflammatory bowel disease. Your inflammatory bowel diseases that we are covering are your Crohn's disease and ulcerative colitis. We're going to talk about locally active and systemic anti-inflammatory drugs for the Crohn's and the ulcerative colitis. So our first drug is sulfasalazine. In your Pearson text, page 701, there's a whole pharmacological section there. And then also on Pearson on page 703 has a chart of your inflammatory bowel drugs. So your first one, sulfasalazine, is listed there. It's also in your drug handbook on page 1095. Okay, so your sulfasalazine is a disease-modifying anti-rheumatic drug. In your drug handbook, it has it listed as 5-amino salicylic acid derivative, which is, and it works as an anti-inflammatory. The action is, well, use is mild to moderate ulcerative colitis on page 1096 of your drug handbook. In ulcerative colitis, it's also used for Crohn's disease. On your contraindications, allergy to sulfur or salicylate. Remember, aspirin is a salicylate. Contraindicated if you have a GI or GU obstruction. See there your caution: severe allergies and bronchial asthma, renal or hepatic impairment, G6PD deficiency, and blood dyscrasias. So you're not a contraindicating, but it is a caution, especially because the sulfur allergy. So you would know that you need to monitor, or you need to in advance. Where does it say here? It talks about it. Indications, nursing considerations, to do an initial urinalysis, CBC, your renal function and liver function test, because it may impair your renal and hepatic, and you would figure that those are some things you would monitor. A G6PD deficiency is an enzyme deficiency that is not tested for often, but if you're going to do on sulfasalazine, you would have to check for this deficiency. Blood dyscrasias, you're looking at changes in your white blood count, your platelets, or multiple things. I put here, note, absorbed by intestinal flora in the colon, because this is under action. You see that it is a topical rather than a systemic drug. So that doesn't cause these anti-inflammatory. It's anti-inflammatory topically, specifically to that colon. That's why it's used to treat Crohn's and ulcerative colitis. Then we go to your side effects. Let me look in your drug handbook. Interactions. So in your drug handbook, still on 1096, drug interactions, hepatotoxic meds such as acetaminophen, which is metabolized in your liver, and INH, your simvastatin, which is a cholesterol medicine, and your SSRIs can all impact your liver function, hepatic function. So doing sulfasalazine in combination, it may cause some liver hepatotoxicity. Also, your herbal interactions, your Don Kai and your St. John's wort, impairs your folate absorption, so they may need to be on a folate, or I think it's a B6 supplement, but you wouldn't want to take it at the same time as your sulfasalazine. It is given orally. They taper the dose from starting until they reach a maintenance dose. Here we are in side effects on page 1097 in your drug handbook. I put here the most common ones: anorexia, nausea, vomiting, abdominal pain, rash, urticaria, and orange-colored urine or skin. So that is a teaching. You'll find it on your patient family teaching. May cause orange-yellow discoloration of your urine and skin. That will go away when the medication is stopped. But as long as they're taking medication, they may have this orange color of the urine and or their skin. This anorexia, nausea, vomiting, abdominal pain can be initially and should resolve as they adjust doses. They may reoccur till their body adjusts to that dose, and eventually when they're on a maintenance dose, those problems should lessen or resolve. Your adverse effects or toxic reactions, also listed on 1097, fever, sore throat, purpura, shortness of breath. You're also looking for, I've shown in the past, we talked about significant allergic reactions with drugs, your anaphylaxis, Stevens-Johnson syndrome, hematologic toxicity, and hepatotoxicity. I talked about your baseline under your nursing considerations. Go to your next slide here. So your patient teaching, taking with 8 ounces of water and food, avoiding ultraviolet light and direct sunlight, reporting skin changes and bleeding. Even though they may have the orange color, there's other skin changes and bleeding, bruising, things that need to be talked about. Here on your intervention evaluation on 1097, it talks about your renal function, that you need to keep flushing the kidney. Adequate hydration is a minimum of 1,500 mLs in 24 hours to prevent that kidney toxicity. You're watching for skin rash and discontinuing the drug because of this, but notifying the provider. Watching their bowel, teach them to watch their stool consistency. If they're getting diarrhea due to the ulcerative colitis or Crohn's, they may need to increase the dose. Report any bleeding, ecchymosis, fever, pharyngitis, that's a sore throat, pallor, weakness. They are monitoring the liver function test. I put on here considerations: monitor stool consistency, watching the skin, the renal, hepatic, hematological function, definitely monitoring their iron O, checking for CNS symptoms such as headache, vertigo, insomnia, hallucinations. They can have a fulminating hepatic necrosis, so it's very, very important to watch for that. Many drug interactions. So I did do a slide. Your drug interactions are phenytoin or dilantin, digoxin, glyphoside, and metformin, both for diabetes, warfarin, which is your Coumadin, your clotting blood disgracers, your St. John's wort, and your Don Key. Multiple drug interactions. So if I didn't mention it, you don't need to go there. Those are the points that you need to be aware of with your sulfasalazine. I'm looking in your text to see. Oh, your text does talk about suppositories or retention enemas. That's sulfasalazine. I don't think sulfasalazine one that can be given that way. So never mind that I said that. Let's move on to the next drug, which is your adalimumab. I hate these generic names. I think everybody would know it as your Humira, which is also in your drug handbook, page 25. Also in your Pearson textbook on page 703 in your chart. It is one of your biologics or your TNF, tumor necrosis factor inhibitors. This is the only one we're going to cover in that section here. Action is to suppress inflammation. It is given by injection only, so you're assessing the injection site for redness, itching, bruising, pain, and swelling. Also, that's part of your patient teaching because you will teach the patient to give their injections. There is an increased risk for opportunistic infections, especially TB. So will do a TB test prior to starting. Risk for hepatosplenic lymphoma. It's used in ulcerative colitis that is unresponsive to other immunosuppressants and moderate to severe Crohn's disease. It does have other uses, but our focus here is in our GI or inflammation disorders. Looking in your drug handbook some more, let's see here. Page 25, you have that black box alert talking about the risk for infections, tuberculosis, lymphomas. So obviously when you get over here to your, where is it? Contraindications. Oh, I just saw it. Right in front of my face. On your precautions, caution for people with chronic infections, at risk for infections, elderly, and invasive fungal infections, and if they have a history of malignancies, because they have opportunistic infections and they can form this hepatosplenic lymphoma. We talked about the uses of it. It's got a long half-life, 10 to 20 days. The only interaction for you to focus on is the herbal echinacea, because echinacea boosts the immune system, and we're trying to suppress this immune response the body's having. The lab values under interactions in your drug handbook may increase your serum cholesterol, other lipids, and your alkaline phosphatase, which is part of in your CMP, complete metabolic panel. Your alk phos is sometimes linked to your liver and more to your bone. Administration, it is refrigerated. It discard what's not given as far as your patient teaching. It's administered subcutaneously. Let's see, let's go to your next slide here with your patient teaching. Inject in the lower abdomen or the thigh. Always give the injection at least an inch away from the previous injection and avoid areas within 2 inches of the navel. They are not to get live vaccines while they're on this because of their risk of infection and their body's not and suppressing the immune system. Through side effects, page 27. Side effects: injection site erythema, pruritus, pain, swelling. Adverse toxic reactions on page 27 is that rash, urticaria, hypotension, dyspnea, upper respiratory infections, bronchitis, urinary tract infections, high risk of serious infections such as cellulitis, TB, and pneumonia. May increase risk of reactivation of Hep B virus if they're chronic carriers. May increase risk of malignancies. Baseline assessment, of course, is checking for tuberculosis, getting all these labs. If the patient is to self-administer under baseline considerations on nursing considerations, instruct on subcutaneous injection, including areas of the body acceptable for injection. Interventions, your labs, your CBC, checking for pain, stiffness, swelling, increased joint mobility. That's probably like for these people with RA. Never mind, I didn't say that. Do not receive live vaccines, which I said, and that covers everything you need to know out of this. I try to pull out the pieces specific for your Crohn's and ulcerative colitis. The next drug we're going to cover is loperamide. Loperamide is mentioned on page 701 of your Pearson. It just talks about antidiarrheal agents given to slow GI motility and reduce diarrhea for patients with mild chronic manifestations, but not given to during acute attacks. So it's also in your drug handbook on page 715. It is an antidiarrheal for chronic diarrhea due to inflammatory bowel. Under your uses, it's not for an acute, it's precaution not to be used during acute episode of acute ulcerative colitis. Action is to slow the intestinal mobility. It's contraindicated if it's acute ulcerative colitis, if they have pseudomembranous colitis, C. diff. Page 716 in your drug handbook. May increase levels of other drugs that have caused QT, prolonged agents. I don't think I'm going to ask you anything on that. Side effects are rare, just maybe causing some dry mouth on your teaching. Nursing considerations, watching for GI bleeding. Stop if there's a chance of any bowel obstruction. You're watching their fluid intake. Your patient teaching max of 16 milligrams a day. Increase the fluid intake may cause dry mouth and drowsiness. And for the nurse to assess their bowel activity and function, and that's all you need to know on this drug. Corticosteroids. Corticosteroids on Pearson on page 701, it mentions corticosteroids with IBD and with your ulcerative colitis. The corticosteroids, and there's an overall section in your drug handbook that starts on 111C. They are given to decrease inflammation, to suppress the immune system, and to decrease the action of the lymphatic system that is aggravating this an autoimmune disorder. I gave you some names. Those are the only ones where I'm not going in great detail. Just to be familiar with dexamethasone, which is Decadron, hydrocortisone or Solucortef, methylprednisone, which is Solumedrol, and then prednisone. Prednisone is the one can only be given orally. The rest of them can be given. Like your dexamethasone can be given IV and orally. They all can be given IV, IM, or orally, except for your prednisone. Adverse effects: headache, insomnia, weight gain, increased blood glucose. The weight gain is usually temporary. Sometimes people get an increased appetite that causes weight gain. Sometimes it's just a fluid thing. It increases blood glucose. Even if you're not diabetic, prolonged use of it affects your body and you can develop diabetes. So your nursing considerations are to monitor the weight, monitor their glucose levels, teach them to report swelling, that's that fluid retention, the weight gain, loss of appetite, fatigue. They need strict oral hygiene because there is a risk of causing candidias, especially in the mouth. Sometimes, in the mouth or mouth sores. That's all you need to know for this section on corticosteroids. Now we're going to go into the diseases for the drugs for peptic ulcer disease. Okay, there is nothing for you to look up in your drug handbook. Your text talks let's see, page 718, 719 in your Pearson has a pharmacological therapy section. I'm not going into all your PPIs and your H2 blockers because you should have that down at this point. If you think you need to, you should review them. I'm going to focus on your H. pylori infection that can cause peptic ulcer diseases. There's two types of treatment, triple therapy and quadruple therapy. And these are what they are. The triple therapy is 2 antibiotics with a proton pump inhibitor. Quadruple is the 2 antibiotics, proton pump inhibitor, and bismuth. I listed here the medications, the antibiotics that would be used. It's 2 of the 3 listed: clarithromycin, amoxicillin, metronidazole, and the quadruple is metronidazole or tetracycline with these other drugs. It's a difficult infection to get rid of. You're giving the proton pump inhibitor or the bismuth to decrease the gastric acid contents. The PPIs bind with the acid-secreting enzymes that function as proton pump, and the H2 blockers, which may be used inhibit the histamine binding to receptors in the gastric parietal cells and reduce acid secretion. So your, hang on. The next page here, I'm going to break down the different things here, like your things to protect your mucosa and your bismuth. So, sulforaphate or caraphate is a drug that literally coats. It is not absorbed. It coats the GI tract. It may be used as long. It takes about 8 weeks for healing when you're coating it. It needs to be taken on empty stomach. No other medications within 2 hours of taking the caraphate sulforaphate because they will not absorb. It can be used once a day to 3 times a day. Sometimes they take a capsule, or it can be made into a slurry that coats because the capsule is huge. Major adverse effect is constipation. The more times a day it's taken, the more highest risk of constipation. Some people get some nausea and dizziness with it. Your bismuth is your good old Pepto-Bismol. That's why I put that name up there for you. Bismuth subsalicylate, if you look at the name salicylate, know that it is an aspirin content, so it is not given in children with a GI upset in case it's flu-like symptoms and this DeVry syndrome. Watch for bleeding. It can cause dark tarry stools that are not necessarily due to bleeding. It can be a side effect. This bismuth stimulates mucosal bicarbonate and prostaglandin production to promote ulcer healing. That's why it is used back here at bismuth with a PPI and antibiotics for treating the ulcers due to H. pylori. It also has an antibacterial action as why it is part of that quadruple therapy. Antacids that stimulate the gastric mucosal defenses. Bismuth. Note that your antibiotics, if you're taking the bismuth as part of that quadruple treatment, the antibiotics have to be taken 1 hour before or 3 hours after, a minimum of 1 hour before and a minimum of 3 hours after the dose of the antibiotic, or the bismuth will obstruct the absorption of the antibiotic. So your antacids stimulate gastric mucosal defenses. Mylanta, Maalox, Alternagel, remember the ones with the M are the ones that have magnesium in it. Some of the antacids, especially ones magnesium, may cause some diarrhea or loosening of the stools. There is one, I'm trying to think of which one it is that doesn't have the M in its name. Gaviscon. Okay. And then misoprostol or prostaglandin analog, I did put page 785. It is in your drug handbook, but you do not need to look it up. Just knowing it stimulates mucus and bicarbonate secretion, inhibits gastric secretions. This is usually used for that person that has an NSAID-induced gastric ulcer. Even though we're dealing with peptic ulcers, you can still even get a peptic ulcer, but if it's due to NSAIDs because the NSAID blocks the prostaglandin, this misoprostol takes that place of that prostaglandin doing what the prostaglandin would do. It is absolutely contraindicated in pregnancy. It should be avoided in fertile women during pregnancy. Reproductive ages, because it will cause a miscarriage in pregnancy. There is caution in renal impairment and cardiovascular disease. It can be used cautiously. And avoid the magnesium-containing antacids, Mylanta, Maalox, and Gaviscon, because of the potential for diarrhea. There's a potential of diarrhea with misoprostol, and combined with the magnesium, and acids will worsen it. It is best to take misoprostol right after the meal to decrease the diarrheal effect, and absolutely contraindicated in pregnancy. That's everything you need to know. And this drug And that is all the drugs you need to know for your Module 10 inflammatory.